Yeah, next speaker is Dr. Kumar. Dr. Kumar, can you please start sharing? He is the director of Dr. Eye Institute, Mumbai, a very well-renowned and daring surgeon, recognized for his expertise in cataract and refractive surgery. Over to you, Dr. Kumar. We can't hear you.
Kumar, you unmute yourself.
We still can't hear you, please.
So this is the first case, which is a decentered femtope flap. So you'll be surprised that the flap actually begins at the margin of the pupil. And I went till the conjunctiva. So this is the femto flap that you're seeing here. And now the question here is what to do. So there was already some discussion on a thing like this in the previous session and in this previous few talks that we've had. So here the question was what to do. Now this was in my initial thing. This is a very old video, almost 6-7 years, or rather 8 years old, when I started femto. The question here is what to do. Of course, we don't lift such a flap. There's no discussion on that. I even hit the conjunctiva. You saw some subconjunctival hemorrhage. So I left it and I called the patient back after a week. Now the question here was to go deeper. The answer is yes. In my knowledge, we have to go deeper by 20 to 25 microns. And where to lift the flap once you created it. So this is the same patient and we are recutting. And the question here would be where to start the discussion of the dissection of the flap. So you can see that I've recut the same eye and I'm starting to dissect on the area where there was no flap. And that will get me the depth what I want. So the question of getting a wedge and something extra, another flap, all that will be completely lost. So here I started dissection far away from the area. So if I even pause this video, the dissection actually began in the area where there was no flap at all. So here you can see that I'm starting the dissection. This is the creation of the flap. And I'm going to pause here. And once I pause and I've started the dissection in this area where there was no flap created, the initial flap, if you remember, was here. So I've started dissection here and this plane is going to be deeper than the plane that was here. And that's the reason why it's quite easier and safe to do. So this was my thought that we have to go at least 20-25 microns deeper. It does very, very well. You can do it in the same sitting. Then I was little inexperienced. And so I waited for a week and then refracted the patient again. There was no change in refraction and then went ahead and then make. So you can see a little bit of effort in the dissection in that area, but otherwise the cut is very, very good and continue with the ablation and this goes ahead. So this patient ultimately did very, very well. There's one more case that I'm going to show. So that patient had had an RK surgery. This is once you've done this, just place the flap back and everything is good. The second case that I'm going to show is the patient had an RK surgery and that RK had done a microkeratome to remove the extra refractive error that was there. Of course, the question of predictability about that is not really there. We know that the RK scars will not give you as much predictability as what you would want, but they do reasonably well. So this is not a 16 or a 32 cut RK. This is an 8 cut RK, had a refractive error. So I went ahead and made a microkeratome cut. And what I saw next day was something very surprising. So I do put a contact lens, many reasons for me to use a contact lens. So next day, the patient had rubbed the eye in sleep by mistake. So this is the re-epithelialization that has happened, okay? And this is what I'm removing. And you can actually see that this is the cut on the RK. This is our pupil. And we can see two actual different flaps, which has actually got dissected and torn across. So this can happen. It's not only because it's RK, this can also happen in any microkeratome procedure. But now the question here is, what is to be done next? So actually my RK cut itself helped me to align the flap back. So I didn't really need to mark anything or anything like that. I use a pendular microkeratome, which normally I use a superior hinge. And that's the reason why you can see that the superior part is nice, well aligned. And just make sure that all the epithelium from the edges are taken away. Make sure that there's no debris down and also invert the flap and remove all the epithelial islets which are there at the edge of the flap. And I put the flap back and aligned it. So here, the question of the flap being upside down, the stromal side up, the epithelial side up really didn't matter because the RK cut itself is helping me to align the flap back. Make sure there is no debris. Once all that is done, we wash. The question here was, should we take sutures or not take sutures? When you have such a large torn flap, what would happen? But I decided not to take sutures. And I also have an image of first day post-op, and the patient did extremely well. So here I'm just making sure that the flap is well aligned. Of course, I would put a contact lens on this. The contact lens I normally dip in moxifloxacin or any type of antibiotic for 20 minutes. It acts as a depot for the first 24 hours. In such a case, I would like to put the lens for a longer time. So maybe 48 hours, 2 days or 2.5, 3 days. So this is the post-op next day. You can't even make out very, very clear cornea. Everything looks fine. Alignment is good and everything is good. So these are the two cases of a decentered femtoflap and an RK operated patient who underwent microkeratome LASIK and had a torn flap the next day. Thank you, Chitra.
Amazingly managed case, Kumar. As far as the first case where you had that decentered flap, if you are planning to do it on the same sitting, which you could have done, which is what you would do is, of course, take a deeper flap as you did. But I think we should wait for the OBL to disappear before we start the redone so that it becomes easier for us to do. And the other thing about your second case, which was also very well shown, what point we need to understand from him is he's also mentioned that the epithelium beyond the edge has to be also scraped off so that we do not seed any nests there. But I just want to ask you, this amount of traumatized flap, would you even think of using a mitomycin in this case, although you have not seen any epithelial ingrowth?
Not really. In first attempt, I wouldn't. I mean, this was the first day post-op. I saw it the next day. So I wouldn't think of using mitomycin. But definitely all the islets of epithelium which are at the edge of the flap and on the other side of the flap, I would 100% remove. Only question here in the first case, I would like to add a comment and take home messages that why did I have such a decentered flap on my femto? That's the question number one. And how do I prevent this from happening again ever in the future? So the summary here is the take home message I would like to give is that you have to understand your technology. Now what happens, I have a Zimmer Z4. It's a brilliant tool, cuts beautifully, everything is fine. But what it does, it takes an image of the cornea and puts it on the screen. Okay, and then starts the femto flap making. So actually when we are putting an applanation, okay, we are increasing the pressure on the eye. And when we freeze the applanation onto the cornea and make sure that we have got the suction on, if the patient suddenly moves the eye, we will not be able to see this on the screen. So the take home message is whatever technology we are using, we have to go into the depth of it and realize what really went wrong. So I've realized that the image that is on the screen is the frozen image because no femto has an active eye tracker. Okay, once you got your applanation, once you got your suction, there is no tracking happening of the eye. So at that stage, if that millisecond, if the eye moves, you can get a decentered flap. That is as far as the Zimmer was concerned.
Yes, thanks a lot, Kumar. That's wonderful.